can hear you. Hey, Brandy, can you hear us?
Yes.
Okay.
Everything under control? Okay, now.
Yes.
And right there.
And then do this slideshow.
Yes, ma'am.
And then do this
Understanding?
here.
All right. Does that look good?
Perfect.
Okay.
Yes.
Can you hear me?
Yes, I can.
Perfect. And then I just do stop slideshow.
Yep, when you're all done, you just hit stop sharing. You are good to go.
So the residents who is going to tell me when to go.
Yeah, one of the chief residents will introduce you at 8, and then once they're finished, you can start.
Okay, let me just say this, right? Okay,
Yep, there you go.
thank you so
You're welcome.
kindly.
Do you want me to stay down
For
here?
just a few seconds and start. Yeah.
I will.
You're so kind.
Oh, absolutely.
I'm just going to.
Okay. No, we'll see it going on the PowerPoint.
Good morning, everyone. Welcome to this week's Medicine Grand Rounds. Just a few reminders for those joining remotely. Please make sure your mics are muted to avoid any unintended interruptions for our speaker today. Please ensure your full name is on your Zoom login so you can easily be identified. And if you're logged in as a group, please email Department of Medicine Grand Rounds to receive credit for today's lecture. If you have not participated and received credit for Grand Rounds via Zoom before, please complete the credit request form located in the chat box during the Zoom lecture. This ensures we have all the appropriate information on file. We will save time for Q&A at the end, and if you type your questions in the chat, I will work to relay those to our speaker. We will try to wrap up around 8:55 in order to get back to our clinical duties. With that, we are thankful to have Dr. Kaku. Dr. Kaku completed internal medicine residency at George Washington University and infectious diseases fellowship at the University of Florida. She joined us at WVU not long after and has been with the Department of Medicine since 1976. She has won countless outstanding faculty and teaching awards. She served as governor for the American College of Physicians, American Society of Internal Medicine from 1999 to 2003. She has over 50 research publications and continues to engage medical students, residents, and fellows in her ongoing projects. She has supported WVU throughout many changes and has been integral in WVU's response to COVID-19. Please join me in welcoming Dr. Kaku.
Thank you for that introduction and good morning to everyone. So why did I choose to talk about syphilis today? As you know, syphilis continues to be a problem. It has been talked about as a masquerading illness or masquerading problem. It continues to do that. It has also been called a stealth pathogen. Even though syphilis is an old disease, we have known about syphilis for a very long time. It still is continuing to make issues or create issues of not being found out, so to speak, being a stealth pathogen. So the objectives for the Grand Rounds are to delineate some aspects of history, because we can always learn from history, to discuss epidemiology. As you know, the numbers of cases are increasing throughout the world and also in the United States and in our state, to discuss some microbiologic aspects of this old pathogen, and to talk about some typical and atypical presentations. And I can tell you, I see Dr. Joy Jaskovich with us, but she and I saw a patient that actually stimulated me to also discuss this patient, because he had atypical presentations and that had delayed his diagnosis before he was being referred to different places. And then CDC has just put out July of 2021 new guidelines for treatment of syphilis that we all should kind of be concerned about and looked at, and then to discuss prevention. So the history is very long and complex and still not resolved after all these hundreds of years. And so what is the problem? The problem is that there has been a differentiation of Treponema pallidum, which is a sexually transmitted treponem, and there are a number of non-sexually transmitted treponems. And there are debates, the continued debates of where it came from. Did it come from the New World and go to Old World, or did it start from the Old World and come to New World? And even with the newer molecular and other techniques, this has not been resolved. And as you recall, I'm sure you read somewhere that Columbus brought it to back to the Old World, etc. So there's a pre-Columbian theories and post-Columbian theories. However, there were many patients with rashes in Europe called the Gret pox after Columbus returned to Europe, and the true unrelated story possibly, but people don't know really, was that syphilis or something else. It was called Gret pox to distinguish from smallpox. So and then there was a lot of writing. Everybody was calling it somebody else's disease. So it was called French disease for some time, and some other country diseases at other times. So there was this Fracastro, who was a poet. He was writing about details or clinical pictures on treatment of syphilis. And he, in his poem and in his works, he talked about a shepherd called Syphilius, who contracted syphilis because he did not pray for the god of sun god. And that's where the word syphilis comes from the shepherd's syphilis. So some of the things we have learned and we are still doing are from long gone past. So the Oslo study from Oslo by a person named Beck, and then subsequently some other pathologists continued this program. And what they were doing is reporting on the untreated syphilis patients. And at that time, remember, this was not the time when we had treatments for syphilis, at least not penicillin. And so they followed patients. These were primary patients with primary syphilis, secondary syphilis, other syphilis, and they followed this 1978 untreated patients. And they stopped the studies when arsphenamine became available. Some of you know that arsenics were being used for treatment of syphilis. And subsequent other investigators followed what they did. And this is where our current latent syphilis information comes from. So basically what they showed is that 24% or so patients develop one or more relapses after they got syphilis, but most of them were in the 1 year. And that is where the early latent syphilis information comes from and is still in the CDC guidelines. That comes from that study that during first year of syphilis, even latent, then you can have patients can have relapses, and most of the relapses are in the first year. So the current era of syphilis came in 1903 when there was inoculation of female chimpanzees with the Treponema pallidum, and then the chimpanzee developed secondary syphilis. And then the Chardin and his colleagues, they identified what they call S. pallidus at the time, which is now Treponema pallidum, from lymph nodes and the chancre. So this is more the semi-modern history of syphilis. And then the dark field microscopy, which is still used in some places, was developed by Landsteiner and his colleagues. And then, believe it or not, we are still using some version of what Wasserman described in 1906. And there was, he developed the complement fixation test and basically liver of stillborn infants. And then it was shown that the liver didn't even need to have treponema to have this complement fixation test. So our non-treponema tests are derived from this Wasserman reaction. It still was used a lot. And then the next era started when people really thought they had the treatment, and that was the development of arsphenamine that lasted a long time, many decades. It was 1910 by Ehrlich, and actually got the Nobel Prize. So and then the first time the isolation of organisms came up, and that is the rabbit inoculation, which is still used today in research for CDC and other research areas. And so this was isolation of the organism from CSF with this, and then even when, as you know, Treponema pallidum genome has been sequenced, and this was from this what's called Nicholas strain. And then there was a long period of this. It's known that Treponema pallidum is heat intolerant. And so people said, well, if we can give malaria parasites to patients with neurosyphilis, and this was a fever-inducing treatment of neurosyphilis, and they would let the people have several febrile episodes and then give them quinine for treatment. And 10% of people died. And so there's a long history of use of fever-inducing treatment of neurosyphilis. And then the first penicillin treatment came from Dr. Mahoney and his colleagues. And I put it in the reference in 1944, they published. So what they did is the first treatment was in the rabbits, and then they had 4 patients with syphilis that they treated. And they were giving 25,000 units every 4 hours for 8 days. And then they followed the patients for a while. So 3 of their 4 patients, these were patients with chancres. Chancres improved patients did find. One of the 4 patients, the the non-treponemal test did not go down as expected, and it was a reinfection actually. And then they subsequently did more than 100 patients, and they published their article. And so that's the first penicillin treatment, and penicillin still remains the drug of choice, as you know. And then the unfortunate study that was done, the 1932 to 72 study of Tuskegee study, where they followed African-American patients. There was a high prevalence of syphilis in Macon County in Alabama. And so this was a US Public Health Service study because people didn't know what would happen with latent syphilis, whether they needed to be treated or didn't need to be treated. Unfortunately, there was no informed consent, and realized that by that time, penicillin had become available and the patients were not offered penicillin. So there's a lot of ethical and other violations and problems with the study. But unfortunately, as you know, 50% of patients who are infected for 10 years had cardiovascular involvement, and most of the deaths were from neurological cardiovascular involvement. And a lot of our research protocols and informed consents come from that situation. So the patient that I told you about, that Dr. Juskovich and I saw, and I'm really grateful for her help. She took pictures and shared. So this was a 38-year-old male we both saw in the infectious disease clinic. He had presented to his PCP because of a tongue lesion. And then they did a CT scan because it's concerned about malignancy. And it showed cervical adenopathy and the tongue mass. And then referral to otolaryngology, had a PET scan done, again showed the tongue mass, and he underwent biopsy of the tongue. And at that time, at least they knew there was no malignancy, but it had a inflammatory tissue. So this is the tongue mass. Is when Dr. Juskovich and I saw the patient, he had already undergone the biopsy. So this is an ulcerated lesion on the tongue. And this is the CT of the soft tissue, which shows the lymph node and this sort of necrosis on this lymph node on the left. And you can see the tongue mass here. This is before we saw him. This was, and after he had the biopsy when we saw him already done. And this, they did the PET scan, which further kind of enhanced a concern that this was malignancy. And you can see the metabolic activity on the tongue mass. So then he was referred to dermatology, because then he had a few lesions on the chest, on the skin and chin and face. And they did that biopsy was by dermatology was done. Again, it showed microabscesses, but some inflammation. So there was no answer up to that point because, you know, the people were worried about malignancy, so on. And as you can see, his rash was not so dramatic. He did have a few lesions. He had a couple of lesions on his palms. The picture was not so great to enlarge, so I not included that. But anyway, you can see that many times it's not as dramatic as sometimes some of the pictures show, so we need to be mindful of that. So this is a skin biopsy just showing extensive amounts of inflammatory tissue. So in histopathology of syphilis, the inflammatory cells can be typically a mononuclear cells, plasma cells, lymphocytes, and eventually they get something called endarteritis obliterans. The vessels are involved. So this one, after Dr. Juskovich and I saw the patient, we asked pathologists to do immunohistochemical stains. And you see there was positive for spirochetes. And so this stain is used now, and unfortunately it's not done on site. They have to send it out, but it demonstrates the spirochetes on the stain. And his tongue biopsy also, as you know, it was not malignancy, it was inflammation. So again, we did the immunohistochemical stain, which shows the spirochetes. The silver stain was done. A silver stain is traditionally been used. Sensitivity is low, and sometimes people have hard time depending on the experience. They might have some reticulin fibers, etc. So it was when we saw him, he had been referred to us by dermatology, and he had a past history of injection drug use for a short period of time, oral other oral opioids and amphetamines. And when we saw him, he told us about this rash. He had rash on his palm soles and the rash I showed you. And he said, "Oh, I have this flashing light in my right eye. And when we talked to him, he had reported a new sexual partner for 2 months. He had been married for 22 years, but they were separated for now. His vital signs are listed here. So the only thing was he had this rash involving palms and soles. It was very subtle. He had some other lesions on the anterior part of the chest and abdomen. Eyes examination did not show any erythema or drainage, and we asked the ophthalmologist to see, because we were concerned about retinitis with this flashing light that he was reporting. He had this genital lesion that he had not complained to anyone about. It's more than one lesion, as you can see, quite indurated. And this was from ophthalmologist also shared this with us, and they did a fluorescent angiography, and you can see the evidence of retinitis. And his treponema antibody reactive, his RPR was 1 to 128. His HIV screen was negative, and he didn't have other STIs that were checked for. His MRI was unremarkable. So he needed IV penicillin. He didn't have altered mental status or other things for us to be worried about neurosyphilis at the time. And so he received IV penicillin, but then he didn't want to stay, he signed out, but then we worked hard to get him back, get his treatment done. So he finished his treatment with penicillin, and he had resolution of all symptoms. And there was, he had been advised about partner testing and testing of his wife, and all that was done, and hopefully he'll come back to the clinic now. So in terms of epidemiology, worldwide, the numbers of cases are increasing, depending on where you see. Some places even up to 11 million cases, but generally about 5 million cases per year. It's a lot of syphilis around the world. And in the US, again, the numbers are increased. The latest data from CDC are from 2019. You can see 38,992 cases of primary and secondary syphilis were reported. And I'll show you a graph where you can see that there were high numbers. There were 500,000 cases at the time of the World War II. And then after the penicillin, the cases came down, and off and on there were little increases with the drug use and, as you know, the HIV pandemic. What is also unfortunate is the co-infection, also very high rates of co-infection. So 42% of men who have sex with men who have syphilis, they have high rates of HIV co-infection. So this is the data from, like, as I told you, the numbers came very rapidly down, and then we have had, increased cases. And now, as you can see, these are rates of reported cases of primary and secondary, and parts of the country have high rates, as you can see. West Virginia is here. We got some new data from West Virginia also that I will share. So total numbers of cases and early primary all going up from 2010 to 19. The cases had come down, but now from 2010 going up. And the largest number is men who have sex with men, but also increasing numbers in women, particularly with the drug use, incarceration, other risk factors. And this has also created increased issue with pregnancy and congenital syphilis, which have also been increasing. So since 2013, congenital syphilis has increased. And in last data from CDC 2019, this number of cases were reported. And the problems are there are missed opportunities for prevention in terms of testing and retesting, later part of pregnancy. The transmission of the infection, as we know, syphilis classically is sexual transmission with direct contact, but mother to fetus transmission. And transmission of syphilis in pregnant women can also occur even from latent syphilis. This is important to know because a lot of things are based on this incubation period. So unlike other sexually transmitted infections, there's a longer incubation period. It's a slowly dividing organism. So the mean incubation period is 21 days, but ranges from 10 to 90 days. So you will see 90 days a lot in the recommendations for treatment and for follow-up and so on, based on this long incubation period. So this is just cases of congenital syphilis. As you can see, they have been increasing. And unfortunately, issues of stillbirth, if a woman gets syphilis during pregnancy, premature labor, and congenital syphilis. And the child, the fetus may be born already with signs and symptoms, or these may develop later. Typical things in the neonate may be just sniffles because of involvement of the nasal mucosa. They can have periostitis, they might have, which is called pseudoparalysis, skin rashes. Even bullous rash can be seen in congenital syphilis. The test in the children, in the fetus, is only non-treponemal test, non-treponemal quantitative test. Treponemal tests cannot be done and should not be done for congenital syphilis because of false positive, and no cord blood, just getting blood from the fetus. So these are a bunch of missed opportunities from the CDC, and you can see that the testing was not done, late identification, or seroconversion during pregnancy. I think all the women were being tested early on, but now there's a recommendation to test at 28 weeks and also at delivery in certain areas where they're extremely high risk. So the treatment has to be there at least for 8 weeks or so to prevent transmission. So it's a real big issue, and I'll show you West Virginia numbers here in a minute. So these are the numbers of early syphilis increasing also in our state. These are the numbers again in females, males more than females. And then I got a message from our STD and HIV area in our state, and that they gave me a report of 9 cases of congenital syphilis in 2020 and 6 cases in 2019. So cases are occurring in our state also. So in terms of microbiology, so what do we know about the microbiology? So we all know it's caused by Treponema pallidum, subspecies pallidum. There are other Treponema, as I told you, which cause Yos and Pinta and Bigel. So the investigational model is rabbit inoculation. And there's some co-cultivation with rapid epithelial cells, but as you know, this is not an organism that has been cultured easily and not available clinically for that reason. It's a very slender organism, but long, and it has got flagella, so it has this characteristic motility. The other interesting thing is people have been wondering about the fact that it has remained so penicillin sensitive for so many decades, since the 40s. And people don't know exactly, but this organism has very little ability to uptake some DNA, extraneous DNA. And there are many subtypes being demonstrated now. The genome has been worked out. It's a very small genome actually compared to many different organisms. And it's very slowly dividing. Doubling time is 30 to 33 hours. Compare that to E. coli. In 4 hours, E. coli can become 10 to the 8th. So that also is a challenge in terms of treatment. And that's the reason we use benzathine penicillin, for example, because of this slow multiplication rate. There are many subtypes, and they've not been specifically demonstrated to be involved in any particular problem. I know the CDC has been looking at the subtypes types that were been causing the eye involvement, but there's not a specific one so far. The pathogenesis of this organism has been very difficult to study because it does not survive outside the human host, mammalian host. It is very, very heat intolerant. It's not tolerant to a lot of oxygen, so it's difficult to study. And as I said, the transmission is sexual, or from mother to fetus, mother to child. And then in the past, there was transfusion-related transmission in the US, none since 1966. Around the world, there still might be some transfusion-related transmission. It requires very small number of organisms to cause infection. In one study, it was 10 organisms, and 50% infectious dose is 57 organisms. So, you know, If you think of Salmonella causing GI tract infection, sometimes 100,000 organisms requiring it. So this is almost close to Shigella, for example, 10 organisms. So it's disseminated through lymphatics and blood vessels. It is very good at evading immune response. There is a lot of, there is some immune response. It has got some lipoprotein on its surface that does bring in macrophages and so on. So there is a cell-mediated immune response. There is also some humoral immune response, both IgG and IgM. However, the organism does have real capacity to rapidly move and get into sites where it is sequestered. For example, very early on, about 40% of the time it will be in the CNS. Very quick spread to many areas. It also has ability to penetrate vascular endothelium. It's very rapidly goes. Its two big characteristics that helps it are adhesion. It adheres to endothelial cells, and also this. It's said that it's a stealth pathogen because it evades the fight between innate immunity and adaptive immunity. Both are trying to get it, but it tries to stay above the radar of both those forms of immunity. At some stage that is contained, and that is probably the time, early on with large numbers of organisms in primary and secondary syphilis. And however, the organisms are still around even in the late stage of syphilis. There are still organisms around even in the gammas. So they are sequestered and protected, but off and on, they must get into the bloodstream. For example, in women, in pregnant patients who get it from even latent syphilis, up to 5 years or longer can have transmission to the fetus. So clinical features, we all kind of know the usual standard features, but remember that the chancre that we know, if any of you is wearing a white coat or your coat, you can see the feeling of the chancre is like invert your white coat and feel, of course, put your gloves on, and it's indurated. And however, chancre can be at other sites. And that's what creates some problems. I think like a patient can have oral cavity or chancre in the perirectal area. So the extragenital sites can be real challenging. And in women, sometimes they may be much more difficult than in men because they may be in a small vulval area or the cervix and may go undetected. So we all know the typical presentation of secondary syphilis. The most classic thing is the rash, generalized maculopapular rash. However, the rash can be atypical and can be involving, also there's mucosal involvement, and I'll show you different types of rashes. They also have generalized lymphadenopathy, and think of it as a systemic process. So any organ, many organs are involved. They can have liver involvement with increased alkaline phosphatase, typically renal involvement. Also hair follicles, they can have alopecia. We have seen total alopecia, partial alopecia, and also nail can come off, nails can come off too. So these are some of the more classic presentation of what we all know, palms and soles, and they can be maculopapular, they can be more papillosquamous, more indurated like in this hand, or they can be more subtle like here. So they can take many forms. They are usually non-pruritic. Now this is what is called Lewis maligna. We never saw that before HIV pandemic. But these are some of the kinds of lesions that are more necrotic and ulcerative appearance that normally we wouldn't have thought of syphilis, but they are called Lewis maligna. They can also be somewhat looking like almost fungal, more indurated, but in different formats. So sometimes some atypical rashes can occur. They can have mucosal patches, for example, here. And then hair loss, which can be patchy hair loss, or sometimes even the beard, also perirectal lesions. These are some of the mucosal and other skin lesions. And condylomata lata, these are around mucosal lesions that are teeming with spirochetes. Now, what Dr. Jaskovic and I saw the patient, he was having flashing light in his right eye. And so ocular syphilis, people used to think it only occurs in late stage of syphilis, but can occur at any stage, primary, secondary, late. And any part of the eye can be involved. The typical is uveitis and retinitis, but can involve and have keratitis and iritis. Otosyphilis, again, in the past, people used to think it's late manifestation, but it can occur at any stage of syphilis. Slightly different, a bit more labyrinth kind of involvement in secondary syphilis, but hearing loss, tinnitus, vertigo, balance issues. And they can occur with or without CNS involvement. CDC currently recommends that if you have a person with eye involvement, if there is no ophthalmoplegia and they don't have any CNS issue, then you don't really have to do spinal tap. The neurosyphilis, as I told you, very early on, spirochetes enter CNS. They may not have CNS symptoms. They can develop meningitis type picture with the mononuclear pleocytosis, with increased protein and glucose, increased protein and increased white cells, more than 5 mononuclear type cells. Also meningovascular syphilis, which can occur in the first couple of years. So this is involvement of the vessels and they present like stroke. So this is some of the serologic and other things when you're thinking of neurosyphilis, for example, they can occur anytime since primary infection. So it can be asymptomatic meningeal reaction, which is common, as I told you, 40% of the time CSF, CNS seeding can occur. Then they can get meningitis or meningovascular syphilis, and then late stage syphilis, which is more parenchymal syphilis involving the brain and the dorsal posterior columns. And we will talk about the serologic test, the serum and CSF, serum RPR and VDRL. So the CSF VDRL is a specific test, but sensitivity is low, as you can see, as time goes on. Some of these tests become, this percentage goes down for sensitivity. So latent syphilis, again, divided into early or late. So early is usually first 1 year, but 1 or 2 years. And why is that? Remember the Oslo study? The relapses were occurring in the first, 90% were occurring in the first year. And then tertiary syphilis. Quite large number of patients can develop if they're not treated late syphilis, as was seen in the Tuskegee study. And cardiovascular involvement and neurologic, particularly cardiovascular, can be a symptom or a cause of death. Parenchymal syndromes that we all know about with the neuropsychiatric disturbances and personality change, cognitive issues, and then also posterior column, which can present with a trouble with the diabetic crisis. They can have trouble finding their foot in the space, which position sense problems. And then gametosyphilis. So gammas can be there anywhere, including CNS, bone, skin. And then ocular syphilis, we showed you the retinal part of involvement can occur in any type part of syphilis during early or late syphilis, and any part of eye can be involved. The same with otosyphilis. So I think one of the themes that should come out is, even though they have been so discreetly, we have been distinctly separating some of the syndromes, I think there's a lot of overlap. And then some of the things we need to keep in mind that they can occur at different times. So this is a picture of a gametosyphilis, which we don't see much, but in some parts of the world you might. So you see a granuloma there, but there are still spirochetes there. It's very indurated kind of a lesion that can be in the skin or on the bone typically. So HIV and syphilis, we know that both are transmitted similarly, but also the immunologic cells like macrophages, dendritic cells, they express more co-receptors, allowing HIV to enter, and also T pallidums. Some of the pathogenic, some of the protein material from T pallidum can upregulate HIV. And we talked about the co-infection being high, 42% of MSM with primary and secondary syphilis have HIV infection, and numbers are increasing in patients with HIV. Now, important thing at the beginning of the HIV pandemic, there is a lot of articles on how some of the things are different, similar. Do they have more neurologic issue? Do they present early? Most of the things are similar. There are some different things. One is some different atypical skin lesions. I showed you the one I showed you the necrotizing kind of picture of some of the lesions in patients with HIV, Dues maligna, it's called. Also, they are reported to have multiple chancres. And it's very important to offer HIV and check for other STIs in anybody who presents with syphilis. And CDC currently also recommends offering PrEP and repeating HIV test in 3 months. So maternal risk factors for syphilis, we already talked about some: multiple sexual partners, drug relation with drug and sex, commercially otherwise, incarceration, either no prenatal care, late care, unstable home situation, homelessness, and high risk of spread to the fetus during primary and secondary syphilis, but at any time it can also happen with the latent syphilis, so stillbirth, growth retardation, and congenital syphilis. So it's currently recommended all pregnant women should be tested at initial visit, 28 weeks, and at delivery. And penicillin is the only drug of choice for pregnant patients, and it's the only one that affects the transmission to fetus. So how does one make a diagnosis? So basically, history, physical exam, which we do. The classic was a rabbit infectivity test, which is not done except in research. Dark field microscopy, some of us have done it. It's easy to do, but you have to kind of do it for a while. It takes 20 minutes. You have to do it within 20 minutes because the spirochete will stop being motile. So specificity is high. Sensitivity will vary depending on what is being done. So that is kind of not being done as much here, but it's being done in other parts of the world too. And some places where you're giving care and there's nothing else available, this is something important to learn and do. So this is what it shows. It's a characteristic motility, cannot be done on oral lesions because there are oral spirochetes that can be mistaken. Direct fluorescent antibody, again, not done much. Is at least you can save the thing on slide and can be watched later, but the conjugated monoclonal and other antibodies are currently not available. These are tests have been done before. Direct testing, we did the silver staining. As you can see, it's good if it shows sensitivity is low, but this can be done on tissues when you don't have availability of immunohistochemical staining, but the sensitivity is very low. So we did the immunohistochemical staining on the 2 tissues that I showed you, the skin and the tongue. Specificity is extremely high. Other things that are done now, the NETs, the nucleic acid amplification tests right now, these are helpful now, even in the setting of congenital syphilis. This can be done on placenta, amniotic fluid. It's low sensitivity in CSF, but also on chancres. These are not available on site for us here at Ruby, but they can be sent out. So the tests that we know, the non-treponemal and the treponemal tests, so sensitivity early on for almost all the tests are slightly low. So both VDRL, RPR, sensitivities and specificities are high in secondary syphilis. And then again, slightly low, they get lower again in late syphilis because these are antibody tests and consisting of cardiolipin, lecithin, and cholesterol. So these are host tissue proteins. And some literature suggests some incorporation of this into the membrane of the spirochete. Again, the treponemal test, sensitivity, specificity high. Of the 3 tests, the best one that is being used is a TPPA, treponemal pallidum particle agglutination test, very high specificity. And the secondary syphilis, again, very high sensitivity. The treponemal test, again, pretty high sensitivity, all the tests. But as you go primary lower, then you go high in secondary and then low again in the late stages of syphilis. And there are several approved tests now for recombinant treponemal antigen. The genome has been worked out. So again, they are comparable to manual tests. So far, titers are not available. So these are qualitative tests. So you say, okay, so they are positive, sensitivity high, specificity is high. CSF, the only one that's really useful or being used is BDRL, sensitivity low, specificity high. So you should have a clinical picture, more than 5 white cells, high protein. And in patients with HIV, some of the literature is recommending a high cutoff that you should use because some of the patients have protein increase and cell count increase in setting of HIV. CSF, FTA, ABS is sometimes used. A high sensitivity specificity is low, but they're saying if it's negative, you can pretty much think it is not neurosyphilis, but I think it has to be taken with the clinical picture. False negative tests, again, prozone, very uncommon, but can occur in primary, secondary syphilis if there's a high titer antibody. Again, biologic false positive, these are generally low titer tests. Certain autoimmune diseases, remember the non-treponemal tests are from host tissues, leprosy, yaws, and HIV infection and some other diseases, but there's not very common, but can occur. There are rapid point of care tests, not used as much in the US, but they are good sensitivity and specificity. Again, you do not get a titer, can very much being developed for the world because there are ones that are being developed to check HIV and syphilis at the same time. These are qualitative tests, just like the immunoassays. So traditional algorithm is to do a non-treponemal followed by treponemal. The reverse algorithm, which we are using also at Ruby, is treponemal followed by non-treponemal test. High volume laboratories like to do this because it's a automated platform. Low volume laboratories are likely still utilizing traditional algorithm. The non-treponemal test has been a problem with automated testing. Even here, they stopped doing it. They're doing it now. Once the treponemal test is positive, they are now doing the non-treponemal by the traditional method. The problems are sometimes many more tests are needed because you have a discordant test result that I'll talk to you in a minute. So these are all qualitative tests, immunoassays. So the discordant result are, so for example, your first test is positive, the treponemal test is positive, but it's a qualitative test. What do? Then you do the non-treponemal test, and if it's negative, then you have to do the treponemal test, so that you have already done another test. However, if this TPP is positive, then it is either current or past syphilis, and we as physicians and healthcare professionals have to figure out what's going on. So it has to be based on other information. So you may have to repeat the testing, especially in pregnant patients. You have to really, and others, you have to really follow up another testing in 4 weeks. Penicillin is a drug of choice, we know, for all stages of syphilis. For primary and secondary is one dose, benzathine, and limited studies on ceftriaxone. Pregnant patients only desensitize and give penicillin. Then it's benzathine, penicillin. That's the only preparation because you need a longer acting penicillin. And again, for early, latent, and penicillin 1 dose. Alternate is doxy, but not for pregnant patients. And if you have latent syphilis, which is more than 1 year, or you don't know the duration, and it's for once a week for 3 weeks. And if it's pregnant patient, then you have to desensitize and then use benzathine. So if you're dealing with late syphilis and you know there is no neurosyphilis, in general, spinal tap is recommended for late syphilis. Penicillin once a week for 3 weeks if there is no neurosyphilis. Now for all neurosyphilis and for all otosyphilis and for all ocular syphilis, IV penicillin, like we did for our patient, for 10 to 14 days. And this is a change in the recommendation. They used to recommend benzathine 2.4 million for 3 weeks, when now they're saying it could be 1 to 3 weeks. Ceftriaxone data are limited, but it also can be used if the allergy history is not that dramatic. But in general, it's better to use penicillin. And pregnant women, you must use penicillin. So Yerix-Herxheimer reaction can occur within 24 hours, most of the time in primary, secondary syphilis. And in women who are pregnant, you have to watch because it might induce labor or hospital distress. So follow-up, generally follow-up is for 24 months for some issues, and for primary and secondary, it's up to 12 months. So 1 year or then 2 years. That's general recommendation. You examine the CSF when you have clinical signs of syphilis, neurosyphilis, if they have cranial nerve palsy or meningitis or altered mental status. And when do you retreat? If there is treatment failure, that means they have repeat serologic testing is positive. Or either you repeat the serologic testing. If it doesn't go down and goes up fourfold, that you should be worried about. They are not responding, or they're failure, or they may be infected again. And then patients with HIV, you have to follow them also up to 24 months. Pregnant patients, you again, as I said, you have to repeat testing. If you diagnose early, repeat testing in 8 weeks, and then repeat at delivery. So management of sexual partners, again, if they are for less than 90 days, you treat for presumed syphilis. And partner notification is done with the health departments. Also, when we are taking care of patients, we need to take care and counsel patients on the fact that their partners will need to be treated. Now, if it is more than 90 days, remember the 90 days is the longest incubation period. They still, should be treated presumptively for early, unless you have the serologic test on that patient. And confidential notification, if somebody has primary syphilis, is for 3 months, partners for 3 months, 6 months with secondary syphilis, and 12 months for those with early and latent syphilis. So in summary, hopefully we can say that syphilis has continued to provide challenges, as increased incidence, unfortunately also with increase in congenital syphilis, they are atypical presentation, so we all need to be mindful of those. We are unable to culture T. pallidum and outside the rabbit system, rabbit model. The immune evasion by T. pallidum and ability to survive and disseminate, the genome has been worked out, and we have newer molecular techniques, but there are still problems. It's amazing that in 2021, we are still using tests that were developed by Wasserman, some version of it, at least a non-treponymal test. And that is the only quantitative test we have available, and the only test that is used for follow-up. All the treponymal tests cannot be used for follow-up. Some of those tests are evolving, and reverse algorithm, there are some advantages of some of the patients that you otherwise might miss, but also there are some problems because more testing is needed. Penicillin remains a drug of choice. Resistance, however, to macrolides has been reported. It was reported out of San Francisco, out of Ireland, out of Washington State, etc. But it's not recommended that we use macrolides for the treatment. Prevention is important, including counseling, screening, partner testing, etc. Condom use. CDC also recommends PrEP for talking with the patient. Unfortunately, vaccine is not available. There are ongoing studies with some of the molecular instruments that we have available. Unfortunately, with issues of access to care and other things that we saw even in the COVID pandemic, the social situation, drug use and homelessness and other things are impacting care of these patients. And therefore, we need to be vigilant and try our best for prevention. Thank you so much. I'll be happy to answer any question. I've listed at least some references that you might be interested in. Thank you so much. Any questions? Anything in the chat?
don't see anything in the chat so far.
Okay. Any questions from anyone? I'm happy to learn from all of you. I know that many of you have joined, have a lot of experience, so please share. Yes, Melanie.
Hi, thank you. Thank you, Dr. Kaku. That was really an excellent review. And I just want to comment that you're so right. Back when I was a medical student and resident, we hardly saw cases of syphilis. And it's just, so dramatic that the increase now, and maybe the students and residents, they'll appreciate that they're seeing this. We didn't used to. We thought I remember, I think in the early 90s, even in West Virginia, there was talk of this disease is going to be eliminated by year, I don't know, maybe it was 2010 or something, but if anything, it's been the opposite. So thank you so much for a really great talk.
Thank you for sharing that. I think they're still being missed. I think that's the rash, even though we all think of palms and soles, it can be atypical. So we need to be mindful of that. Just this week, we saw a patient who had seen 1 year ago and was missed, and unfortunately his hair fell off and the nails fell off for untreated syphilis. I have not seen nails falling off before. There was the first one. Other comments, Joy or anyone else?
We do have one comment in the chat here. We have a question. Is there any evidence of drug resistance developing?
Not for penicillin. As I said, it's amazing that it's been around so long, but I think the organism doesn't really have a whole bunch of things so far, hopefully not, to do that. But it has developed resistance to macrolide, and that's well worked out. So I think the molecular techniques available in the genome has been worked out. So I hope that we will learn a bit more about, because it's really hard to depend on one drug and one drug only. For example, pregnancy is pretty scary. And, for meningitis, the data on ceftriaxone are there, but not very, very long. I think the largest data set are for penicillin. Then it's pretty scary, but I think we have lucked out so far. I don't know how long our luck will remain. Because the study, as I told you, was published first time in 1944 for penicillin use. Yes.
You just reminded me of another question, Dr. Ku. Could you comment on any development of vaccine?
Yes, I think with the molecular techniques available, people are really, really trying hard. So, but nothing really out there. But I think that I see a bit more, few more articles. I saw at least an effort being made. So hopefully that will come through. There's many protein small that have been detected. They are trying to figure out which one is really important for pathogenesis and so on. So I think that the worrisome thing is it's such a stealth pathogen. It's around, it goes around, the whole body stays in places, comes out years and years later. And remember, it's not an intracellular pathogen. That's a mistake. And it does not have LPS. So it creates inflammation from other things, protein and lipoprotein on its surface. So it's really interesting organism, but it has been around so long and we're still learning about it. Any other questions, comments? Anybody has seen other patients that they want to share?
Someone in the chat asked, what do you think has contributed to the increased incidence of cases?
It's a very good question. I think that a lot of postulates think, for example, more people having, sexual contact, unprotected sexual contacts, combined, unfortunate combined epidemics of drug use and sexual and multiple sexual partners, social issues, incarcerations, drug and sex, it's just really sad that the whole pandemic, this thing is superimposed on all the other social issues. The other thing is, I think when HIV came in the beginning, there was a lot of fear about it, the antiretroviral therapy, being very good and suppress viral loads and so on. So sometimes people are not as careful in the barrier precautions are not used. Also, they might have more oral contacts, which what I saw in the literature, and so and then they might be less detected or if they don't have the classic lesion. So for a variety of the other thing is called serosorting. So there's some literature on that, and also internet, people finding partners on internet, and serosorting. In other words, people who are HIV infected versus HIV infected, and things like that. So I think there are multiple factors that have really contributed to this. And we are seeing congenital syphilis again, which we never thought we will. And it's not gone away from the rest of the world, as you know. Other questions? Good questions.
In the chat, we have, if an IV drug user has untreated primary syphilis and shares a needle, how easily is syphilis transmitted?
Right, so it has been, there would be a potential, although there's not much written about it. But for example, transfusion, there used to be cases before, and then when in US at least, the FDA just updated its recommendation 2020, and they're pretty strict recommendations. So we really haven't had the amount, the spirochete is not in the blood all the time, even though the person may have syphilis. It's certainly a potential for risk, but there has not been epidemiologic information for any increase, but it's certainly thing. Just to kind of remind yourself, for many years, it was in part of the needle stick protocol in the hospital. And long time ago, when I was first in the US, there were RPR was a normal standard admission testing that was being done. At that time, it used to cost $3. So they used to, so the numbers decreased. And in the employee health, I know the needle stick protocol had RPR testing. Now, whether that will come back, I don't think the numbers are that high, but that's a very good question. And also relates to transplant, for example, solid organ transplants, and there's a lot of testing done, but there have been transplant-related syphilis cases reported in the literature outside of here. So good questions. Other questions? You can just put your hand up and talk if you want. Any other questions or comments? So before I close, I also want to thank our administrative assistant, Donna Weiss, and others who were so helpful, and appreciate everybody's help. This has been a team effort, and hopefully we'll continue to learn about this and help our patients. Thank you very much.